So I am having a breast surgical excisional biopsy next Wednesday, which means I'm going to have a localization prior to this. And since I'm the doctor who usually performs this procedure, I wanted to explain a little bit about the process in case you need one and why I'm having this done in the first place. Hi, I'm Dr. Robin Roth. I'm a breast radiologist, aka the Boovie Docs. So localization procedures are typically performed by radiology prior to breast surgery when there's an area in the breast that needs to be taken out, but the surgeon can't see or feel it. So they ask us to help localize it under imaging. This procedure may be done for cancers in the case of lumpectomy, or if we're taking out high-risk lesions, or in my case, discordant pathology. So localization procedures can be performed under any type of breast imaging wherever it's seen best. Mine will be done under mammogram because we are targeting a biopsy clip, but they could also be done under ultrasound or MRI. So there are basically two ways we can do a localization procedure, with a wire and without a wire. Now I'm going to focus on wire localization because that's the procedure I'm going to be having. Wire localizations are done on the morning of surgery, so the same day. Basically, the radiologist will insert a thin needle and wire into the area that needs to be removed. After we place the wire, we put a little cup over the wire that's hanging out, cue the Madonna joke, and you go straight to the operating room and they take that area out. A radiologist like myself will then look at the surgical specimen and make sure we got the area that we were targeting, and you go home that same day. That is for a wire localization. Now, there are newer wireless localizations which can be performed with radio frequency tags, magnetic tags. They could be nuclear. At our institution, we use a radio frequency tag. And the benefit of a wireless localization is that they can be performed a few days or even a month before surgery, and you don't need to have that wire sticking out of your breast. It's also a lot easier for scheduling for both the doctor and the patient. You basically come back at a later date, and the surgeon will then do the breast surgery. In both cases, we usually get final pathology about a week later. This ensures that the cancer or the area in question was fully removed. It also lets us know the final pathology, which is really important, especially in the case of cancer, because we know if the margins are clear, or if it got upgraded at the time of surgery, or if there was a complete pathologic response. In my case, it will let us know that the area is truly benign. Hopefully it is. There is a small risk of my PASH or pseudoangiomatous stromal hyperplasia being upgraded to something more serious at the time of surgery, but I really feel confident that it's going to be okay because I felt that the biopsy was representative of the imaging findings. I even prospectively called it to be PASH, and I also felt that the biopsy clip was in exactly the right spot where the imaging finding was. But at the same time, I am very thankful that we are taking it out because I think it's the right thing to do because the imaging appearance was suspicious. Also, I mentioned that I'm getting a lift at the same time as my excisional biopsy because we're going to make some lemonade out of these lemons. Anywho, I hope this was helpful. Follow along next week as I undergo my breast surgery and excisional biopsy. And as always, oh my God, it's so hot. And as always, follow the Boovie Docs for more of the breast information.